Okay, welcome everybody. It is 1:30. Welcome to our community health panel on honoring the past and shaping the future. I would love, first of all, just welcome to National Public Health Week. We are so excited. We get excited every single spring to have everybody join us. Thank you for taking the time to join us today. And I'm excited to introduce our panelists very shortly, as soon as I get through a few kind of announcements. First and foremost, I want to thank Dr. Angie Buckner for her leadership and vision for National Public Health Week at SJSU every single year. This year, we were fortunate to have additional faculty support from Maya Itzel Villa, who is a graduate of our campus MPH program and currently a lecturer in our department. We are so grateful for everyone who has been a part of the planning process to make this week a success. This year's American Public Health Association's National Public Health Week focus is called Ready, Set, Action. And we're off to a great start, especially with the Measure A panel that we had yesterday. I hope many of you in the audience were able to attend. It was an incredible panel co-sponsored by the Committee to Enhance Equity and Diversity, SEED, from the College of Health and Human Sciences, and moderated by our very own Dr. Marcel Dugan, who is also the co-chair of SEED. And for those that were not able to attend, the Zoom recording will be available hopefully on our Adobe Express page, which we will place in the chat. For those that didn't get a chance to, am I telling correct? Was it recorded that people will be able to do that?
It was recorded and it will be uploaded to a YouTube channel for people to access.
Fantastic. I'm glad I'm not telling more lies. Okay, excellent. So thank you. Thanks to everyone who participated in the networking mixer hosted by our very own public health clubs, Public Health Honor Society, Public Health Peer Ambassadors, and Public Health Student Association. We had 11 different professionals from different public health sectors to share their public health journeys with our students. And we hope that many of you will be able to join us tomorrow for our last National Public Health Week event, the Vibe and Thrive Mini Health Fair on the Science Lawn near their MLK Junior Library, created by our very own Public Health 104 National Public Health Week Group 20 from 4 to 6 p.m. We will have games, prizes, and fun health facts to share on the topics of nutrition, mental health, cancer prevention, healthy sexuality, and substance use. So thank you for allowing me to make those announcements. Now for what we really came for is for our panel and our guests. So I'm delighted to be able to moderate this panel on the history and future of community health. I wanted to bring this panel to SJSU for the last 3 years due to my community work as a facilitator for the Community Health Partnerships Leadership Academy, which I work very closely with one of our panelists, Dolores Alvarado, and with Patty Diaz, the Director of Community Engagement at CHP, to moderate a panel that we have every single time for our fellows. And I'm really excited to be able to bring this story to San Jose State University. Today, we have 4 incredible panelists joining us. We have Dolores Alvarado, who is the current CEO of Community Health Partnership. We have Luisa Buada, who is the former CEO of Ravenswood Family Health Services, which I just found out is still doing some work with them currently. We have Raimundo Espinosa, the former CEO of Gardner Health Services, and Ricardo Romero, Program Manager with the Language Access Unit at the County of Santa Clara, and a graduate of our very own NPH program. So thank you all for being here and being willing to be a part of this panel. So with that being said, I'm going to start the first question, which is, please share a little bit about yourself and why you're passionate about community health. And I'm going to start that question with Dolores.
Dolores.
You are so evil, Vicky. Why do I love community health, particularly the field of public health within community health centers? There are a couple of reasons. One is more personal than anything. It has to do with the experience I had as a child when I came in as an immigrant. I was 5 years old and then moved to San Francisco. I was 10 and I became the family doctor, believe it or not, which is pretty scary that a 10-year-old would be making medical decisions. That had a huge impact on, what's wrong here? Why am I not outside playing? Why am I translating for my mother's, breast exam or something. So that was one. The second one probably had more of an influence than anything is I had graduated from college, went to graduate school, became a teacher and taught for 3 years. And I did not have any passion for that. Even though I love education, for some reason the combo of kids running around screaming and yelling didn't go with me. That's all I could say. So I was a little lost, and I found a clinic. They were looking for someone who I don't remember what the paper said. We used to do ads in papers, no apps, none of that business, right? And I showed up, and they gave me a job, and the job was like this: we're going to hire you, but we don't really know what you're going to do, but you're going to do something, so we're going to hire you. Imagine doing that these years. You can't do that. You have to have job description, etc. So I was hired, and my first day there, I fell in love with everyone. I fell in love with the fact that folks were there to help others that were disadvantaged in some way, money, immigration issues, recent immigrants, and that it was done as a group. There was this they call it now a vibe when you walk into a room, and the vibe was we're here together, we're a bunch of comadres y compadres. Nobody was related genetically, and we were there for one reason: to make sure that the folks living in the Fruitvale district of Oakland were able to see a doctor when they needed one, were able to see a doctor that spoke their language, we were able to go in and see someone whether they had money or not. That's what I fell in love with because I believe so strongly in that. I always did. My parents taught me that, and that's why I love this field.
Thank you so much, Lourdes, for sharing that. Next, I would love for Luisa to share.
Yes, so I got involved with community health via working with the United Farm Workers Union. My father had been a farm worker when he came to this country, and he actually had married a nurse. My father was from the Philippines. He was a Filipino immigrant, and he married my mother in 1942 when it was against the law for a non-white person to get a license to marry a white person in California. My mom, having grown up in the U.S., she became a nurse, so I was very much exposed to what good health care could be. And so when I in high school, I got involved in boycotting lettuce and grapes in order to support the United Farm Workers Union. When I went to UC Santa Cruz, I actually helped lead the boycott, and then we raised money and food and clothing to take to Coachella to the grape strike in 1973. And while I was there, I got invited to continue to work as a full-time volunteer for the union. And what that meant was working literally 6 days a week for $15 a week, and then getting on food stamps if you could. And I helped fill out food stamp forms for the families of farm workers who were striking. And then I got recruited to work in the Salinas Clinic as a translator. Now, mind you, I did not grow up speaking Spanish. I had taken it in school. And at the time, a lot of my friends who were Chicanos, who were, their parents spoke Spanish, they'd been raised with this idea: you don't speak Spanish because you're in America now. So they didn't want to speak Spanish, so they always pushed me out there to give all these speeches in my horrible Spanish. But I ended up learning how to speak it very well, at least medical Spanish and everything about growing things in the field. So when I went to work in Salinas, I found out for the first time in my life that actually there was no protection for people who didn't have health insurance or money. There was no anti-dumping laws that there are today. And essentially, if you didn't have money or insurance, a hospital could refuse you care. And so people died, or we put them in a car and say, drive as fast as you can to Mexicali or Tijuana to get to a hospital. Women gave birth at home, because even the county hospitals often refuse service to people. And that's really got me passionate about access to care and the whole notion of health justice, that we needed to do something, establish programs and services to serve people and find a way, however we did it, whatever it took, to be able to provide access to people. And that's how I got involved.
Thank you so much for sharing, Luisa. Raimundo, I would love for you to answer the question. Please share a little bit about yourself and why you're passionate about community health.
Oh, you're mute.
Oh, muted. Let's see here.
How's that?
Perfect.
Can you? Okay,
Yes.
okay, yeah. No, so my name is Raimundo Espinosa, and I was raised in the Coachella Valley before there was a Coachella Festival. My dad was a farm worker, but by the time I was raised, he worked in a packing shed, and my mom was at home. Um, so my when I was growing up, I had a lot of trauma. Basically, I didn't realize it. I thought everybody else went through it, but my mom was in a mental institution when I was 10. My sister died at 20 from toxemia. Later on, my sister committed suicide when she was around 28. So there was a lot of trauma related to my upbringing. And initially, I wanted to be a doc, but in light of the 60s and 70s, I wasn't dedicated enough. I wasn't disciplined to do that. And so I was looking for an opportunity to do something else. And so eventually, because of during the time at Stanford, it was there was a lot of turmoil, a lot of activity trying to increase access for Latinos and staff at the center. Initially, I graduated and um, ended up at the School of Public Health in Berkeley with a hospital administration specialty. But nevertheless, my background, because of the trauma that I felt, I always wanted to be in the healthcare field, and that's why I pursued the hospital administration program. And there's a big story behind that, but anyway, I did that, and I took a different route. I right out of my master's, I ended up being an assistant administrator at a hospital. And it probably was the wrong hospital because it was not that it's a bad thing, but it was a a community for older adults. But right outside the wall, the Mexicanos would come in and provide the cleaning and the food and all that stuff. And I wasn't allowed to speak to them in Spanish, so nevertheless, that didn't work out. I left and ended up trying to find my place and wanting to advocate, basically to make change at a human level, at a basic level. But I worked in different positions. One was with the hospital association. The other one was with these quasi-governmental agencies that evaluated hospital growth. My last job was working for a for-profit corporation that grew from 3 hospitals to 30 hospitals in 3 years. In my travels, when I lived I lived in Phoenix, in three different areas in Arizona. I worked in Ventura. I worked in Fresno. I worked in Riverside, and my last job was in the mountains in Big Bear. But in the travels, I came across a person. His name was David Correa, and he was the CEO of Gardner. And he asked me if I wanted. He was going to leave, and I wanted to apply for the position. And I had always been looking for something that I could really be part of, something that would engage me. And it was Gardner. So I was hired at Gardner. Our budget was 1.5 million at that time. And that's where I started, and that's where I fell in love with the corporation and what we were doing to help people better their lives, basically. Because I think historically, community health centers have not only been about the healthcare, it's been everything else, right? It's not you come in for a visit, but do you need clothing? Do you need food? Do you need transportation? It was all about those types of activities that, for me, made it a real, very enticing position to be.
Thank you so much, Raimundo. you were doing, addressing the social determinants of health before it became popular to do so.
Right.
Excellent. Thank you so much. And Ricardo,
Right.
yes, please share a little bit about yourself and why you are passionate about community health.
Of course. Thank you. And yeah, so good afternoon, everyone. My name is Ricardo Romero Morales, and my entire career has been rooted in advancing health equity and strengthening community systems. I actually entered this field because I grew up seeing firsthand the challenges that our community faces. I immigrated to the United States when I was 14 from Mexico. I didn't know English at all. And I was also discovering who I was as a person.
Thank you.
Eventually, years passed, and I identified myself as a gay man. And during that process, one of my partners actually tested positive for HIV. And at that point, I was scared. I didn't know what to do. I didn't know where resources were available. And so that's when I first started to look for resources, learn more about HIV, the methods of transmission, what the risks were, where could I go get tested. And again, I had just immigrated to the States, so I didn't have health insurance. So at that point, it was just another barrier for me to be able to identify where I can go to get tested. Eventually, I was able to get tested. Results came back negative. But ever since, that was a moment where I realized that navigating the system here in the United States as an immigrant is quite challenging, especially if you have so many barriers such as language barrier. In my case, I was not even out of the closet at that point yet, so it wasn't like I could go to my parents or my family members and ask them to guide me and tell them about my exposure. And it was also about finding resources in language that could actually help me to better understand what the results meant, explain to me what a window period was, and trying to fully understand how we can continue to share this type of information with communities who don't have access, who may not speak the language, and who may not even know that these services are actually available to the community. Over the years now, since that moment, I've had the opportunity to work with different nonprofits. I did work with AKI, Asian Americans for Community Involvement, for a number of years. There, I was a HIV counselor, and I was also eventually became a CalWorks counselor. I was on my path to become a mental health counselor. I was going to school. I was getting my PhD in clinical psychology, and as I was doing some of my hours, what I what I really fell in love with was with the fact that taking a step back from seeing clients, what I learned was that many of the times the story was repeating itself over and over. And the most common theme that I was seeing across my clients was the lack of policy to be able to support their resources, their needs, ensuring that we remove barriers, such as ensuring that the information and services are available in the languages that they need, and also at the hours that they need them, at the locations that they need them, and that also the transportation or childcare doesn't become a barrier. Over the years, I've now worked in the public health department. I've continued my work with HIV and STDs there. I've also worked under tobacco prevention and control. I became a youth engagement coordinator, where I had the opportunity to coach youth from different high schools on how to do health advocacy work as it relates to policy prevention work. And now, during COVID-19, actually, I had the opportunity to lead all of the communications related to COVID-19 here from the county of Santa Clara. And from that moment on, that's when I decided that I was positioned, or I was at a place in my career where I could now advocate at a higher level. And that's when I started to advocate to form the very first language access unit in our region, actually. And ever since, we have now been paving the way to many other counties and cities in the country to continue to build a language access infrastructure that can help our community members ensure that they're receiving the information and services that they need in their language.
Ricardo, thank you so much for sharing that and for being able to create like this language access unit, which is needed, and how you did that, like from your experience starting in public health. So thank you so much. for sharing. All right. Okay, the next question that I have, and let's see here. And I feel like you all kind of talked about it, so I'm going to actually ask them two questions. So if you want to tell us more about the context of where you were in your life when you started your work in community health, which I feel like many of you touched upon, but if there's anything else that you want to share there. And why was there a need to create community health clinics? And what was the vision? And I'm going to have Luisa start us off there.
All right. Yeah, so I'll start from EMTALA. EMTALA is the Emergency Medical Treatment Act, something or other, something or other. Anyway, it's the anti-dumping law, and it didn't pass till 1981. So I started working in community health in 1973. It's been 53 years now that I've worked in community health, and the United Farm Workers Union clinic closed in 1977, I think. So I decided to go to nursing school and I graduated in 77, and right afterwards the clinic closed. And so there were about 10,000 farm workers in the Salinas Valley that had been using this little tiny clinic that had 4 exam rooms in a little house on the corner of Alisal Avenue in Salinas. And people didn't know what to do or where to go. And one of my nursing student friends invited me on a trip to Cuba to see their healthcare system. And on the trip were all these people who were running health centers in California. Many of them Raimundo and Dolores know, like Joel Garcia and Castelo de la Rocha, and Francisco Hernandez was working in mental health. And there were just some very prominent people in community health in California on that trip, along with the head of rural health. And she was a Latina woman and was very interested in setting up 2 farm worker clinics in California, one in the Central Valley and one in Salinas. And so Joel was the chair of Jerry Brown's Primary Care Clinics Advisory Committee at the time, and he invited me to join the committee. And from those directors, I learned about how to start a health center because rural health wanted to give a grant for a farm worker clinic in the Salinas Valley. And so they also helped pay for a consultant to help a group of us. So me and the nurses and then community leaders from the United Farm Workers Union came together, worked with California Rural Legal Assistance to form a nonprofit and to put together whatever was necessary to form a clinic. Now, mind you, I was like 25, 26 at the time, but there's something about being 25 and 26 where you think everything is possible and life is forever. And, especially if you are, I wouldn't say I was arrogant, but I thought there was nothing that was impossible at the time. And so I ended up becoming the first executive director because nobody wanted the low paid job after we got the clinic together and got the grant. But I was 27, and I learned on the way. And what I've learned, people have often asked me over the years, as I've ended up helping to start or starting from scratch for health centers in California. They're still in existence as well. Is where do I learn? What class do I take in public health to learn how to start a clinic? And I'd laugh and I'd say, well, fiction. I took a class in fiction. I made it up as I went along because you just go out there and you ask another director, tell me how to do this. Tell me. I mean, the networking among community health clinic directors is so critical to being able to start a clinic, keep it together, learn from each other. And it was that sort of broad network of folks that were very committed to community health and making sure that we all survived together that really brought us forward. But there is still no book that can teach you how to do this. A lot of it is chutzpah. And basically, it's like a mom and pop store. You do everything. It's like if the toilet needs to be unplugged, you unplug the toilet. If you need food for your staff, you go out and you buy tacos and you bring them in. It's whatever it takes, but it's also learning all the real critical things. And in those days, you got to understand, licensing was very light. there was no compliance and quality regulations and things like that. We wanted to do quality care. We hired excellent physicians and nurses and staff. That wasn't the issue, and people cared and were very compassionate about our patients. But what we didn't have was all the regulatory environment we have today. But we got through on passion and not a lot of sleep.
Years.
Yeah.
Thank you so much, Louisa. And so you got to practice also then while you were in that role too, or
Oh yeah, I was a nurse.
Mhm.
Yes, and actually there was a little hiatus in between when I graduated and when the clinic opened, where I was a public health nurse for 3 years. So there was only two public health nurses in the Salinas Health Department at the time, it was Monterey County Health Department, and I got half of the Salinas Valley from Chular all the way to San Ardo and to the mountains. That was my territory, and so I did a lot of public health nursing.
Excellent. Thank you for saying that, just because we have a lot of students in the audience who are very passionate about pursuing nursing as well. So I know that they appreciate hearing that. So thank you, Louisa. Next, I would love for Dolores to weigh in. So I know, Dolores, that you were not a part of, creating the community health, movement, but I know that you worked, in community health. So if you would like to share from that perspective, and I will.
Yeah, I was extremely young when I took that job in 1976. Yes. But I do want to share something that I feel is important, which I learned while I was at School of Public Health at UC Berkeley. The term social determinants of health and health equity and all that, we think we invented that. We did not. There were many people before us that used this term. And there was a doctor in the East Coast that started to notice, I think it was in Alabama or Missouri, one of those two lovely states.
Mhm.
They started to notice that there was a huge difference between black health mortality, black infant mortality, maternal mortality versus Caucasian. And that's when the term started the health disparities was the term. Later it became social determinants of health. And he was the one that started the first community health center in some jungle somewhere, I don't know, somewhere in Alabama or something. He saw the need and he did it. He did it with just a bunch of residents and doctors that were coming from everywhere, etc. But what I do really think it takes to take the plunge and to really become an executive director of a clinic, and we have two of them in the room here, is the opportunity to create, the opportunity to take chances, the opportunity to fight, and fight in a very meaningful way regarding policy, regarding you owe this to us, we have the right to get health care. So it takes a lot of guts. That's the best way I can describe what it takes to start a community health center. The skills around nursing and all those other skills, I think you would agree, Luisa, those are extremely important. But what Luisa had, what Raimundo had, what others, is las ganas and the guts. The guts to fail, the guts to ask what nobody else is asking. That's what makes a good director, in my opinion. I know there's a question about that too, but I think you perhaps wanted me to address this because she hears me talk about this all the time. And you'd be surprised that in the year where we are now, or where we are just even a couple of years ago, that ganas has left us. So we need to bring it back. And we want to talk about that later, I know.
Excellent. Thank you so much, Dolores. And it's, Dr. Geiger, I believe, is the one.
Dr. Geiger, correct?
Mhm.
Mhm.
Yes. So
I
actually,
got to meet him just before he died.
oh, I
Yeah.
love that.
Mhm.
I used to assign an article of his in this class, and I don't anymore. And you know what? I need to bring it back. So thank you for reminding me of that. All right. Raimundo, if you would like to share, why was there a need? And I know also you had a different path, and that wasn't exactly, you weren't, do you know what I mean? Differently positioned, but from your experience.
Yeah, yeah. No, no. So, Alviso, health foundation, or at least a health clinic, the first one in California to be funded by the feds. Started out as a volunteer organization. Why? Because out of necessity. When this was the Valley of Heart's Delight, when it was nothing but orchards and fruit trees and what have you, in Alviso, the population would double because of the migrant farm workers coming to town, and um, and they didn't have access even at the county because it was so far away for them. So they organized with the they organized with the local Catholic Church. They organized with the advocates. They organized with the leaders in the community to start a clinic on a volunteer basis. Eventually, what they did is they were able to convince the city, because at that time they were building the 280, and you could take some of the buildings they wanted to destroy, and so they moved a hotel to land that they were able to convince the city of San Jose to lease it to them for $1 a month. And so that started Alviso. 2 years later, in the Gardner community, which is in the downtown area, um, big need also, high mortality rate, so on and so forth. They also did the same thing. They organized with the local church and the advocates, and they started a clinic right there at the rectory in the church. And because they didn't again have access, and it was about not only for them but for their kids and their kids, and a little bit different because it I think the Gardner was dealing more with the cannery workers and the service workers and all those folks that are folks that couldn't get access to healthcare. Um, so when I was hired at Gardner, it was the first year after they consolidated services from the church. In other words, they had all the services were run out of the church: dental, medical, um, mental health, and so they consolidated into the clinic that I was at, which was the Gardner Health Center, and that was in 1986 when that happened. Um, Again, I think. Um, but I have to take a break for a minute. Anyway, so as a result of coming in, I mean, we were poor. We were poor. Our organization was poor. I mean, they had been on probation from the United Way when I came in. And it was a small organization. But the question was why the need? Because we didn't have any access, and it took a lot to. I don't know if you're going to get into what had to be done, but I think that's the next question. Yeah.
Now I'm the one who's muted. That is the next question, Raimundo. That I would love if you want to continue to share that. Like what needed to happen to make that a reality?
Well,
And what were some of the challenges?
So here I come in, right? I just left a for-profit corporation that grew from three hospitals to 30, but I didn't like it, didn't like their message. They talked a good line, but their actions weren't tied into what they said about people, that they love employees, but they didn't really. So when I got to Gardner, I said, man, we got to create a culture that is embracing. But again, we were poor, and I was trying to figure out how in the heck are we going to start to grow. So fortunately for me, I've been a blessed child. So I had a friend of mine who actually played at our wedding in Brawley, California. He was a consultant. His name was Gilbert Serene. And he came to me and said, "Look, man, the clinics aren't taking advantage of the of the state loan guarantee program, and want to do it." And I said, "Oh man, let's do it. Let's see what we can do." So he said, "Okay, but you got to come up with $180,000 because that's like I think was something like because it was about 10% of the total because it was a $1.85 million project and we had no money, right? so fortunately, at that time, the city had these grants called the community development block grants, and it was the block grants were for buildings um, to address the blight issue, right? So I went to the city and I wanted an application, and they said, "Well, we don't fund healthcare. You can't apply." So, but I got the application anyway and applied, and I got 100,000. Uh, uh, to do to so then I had the whole deal about 80,000. I go, oh man, I don't know how I'm gonna get 80,000. So after breaking my head trying to figure out how I was gonna fund it, I just said I'm just gonna ask the owner, have him donate the 80,000. And for me, it was saying, well, if he donates the 80, he's gonna get 1.3 million. So why wouldn't he do it? So long story short, yeah, we were able to he did donate it and he did get the 1.3 million. But that started us off because it stabilized us by because the fund that we funded created a reserve of about a half a million, which you would get if you didn't access it, and that half a million was for the purpose of um, making sure that that you paid your obligation, and if you didn't, they could take you over and pay it for you and take over administration. But anyway, we paid that loan off early. Later on in 1997, we merged with Viso, which was a bigger corporation, but had gone through a lot of difficulty. When I first got there, they had a $2 million deficit, um, and uh, I had to figure out how to get it out of debt. So we had to cut programs. Unfortunately, just to make even to break even. Um, and eventually I was able to get them out of debt, but I left for a year and came back to Gardner because I had uh, a difference of opinion with the board, and the board, they rule. So once I said no, I knew I was going to get fired or let go and or resign, whatever it was. But it was the best thing that ever happened to me because I became a consultant for a year. But in that year, um, I helped with the Clinica in Salinas as their interim director because they lost them. I helped create the uh, California Primary Care Association. I was working under the leadership of NEMS. They subcontracted with me to bring everybody together to create an association, and so that allowed me to continue to move forward. And then a year later, the Gardner position came up, and I took that over and stabilized that one again, and then took over Family Health Foundation of Alviso. And that there's a whole lot of processes and a whole lot of activities that go behind all of that stuff because they had a blue ribbon committee that took over the operations because they also had one of those loan guarantee programs, and they were not paying their rent, and they missed payments for 9 months, and so the state took them over and invited the feds and the city and the county to participate as a blue ribbon committee to select a new CEO and board, and we volunteered to become that and merge the organizations, and we merged them without eliminating any programs, but assumed responsibility for the administrative responsibilities of the organization. But in terms of the types of things that we had to do, we had to be creative. So when we looked at the organizations, we were smaller. Our budget was 5 million. Their budget was like 18 million, and they were losing money. We only had like a reserve of half a million. We had to figure out how we were going to manage it. So what we did in terms of a merger, it was called an affiliation. And so we kept two different corporations with under the board. And so we closed one meeting for one corporation and then opened the other meeting for the other corporation, but they were all affiliated under the same umbrella. And that allowed us to generate enough revenue to meet the debt that we had and the expenses that we had. Um, so I mean, it Yeah, so it takes a lot. I mean, you have to always be the main thing is keeping an eye on the bottom line and anticipating what's going to happen and trying to prepare as well as you can because you can't really do anything until it actually happens. But trying to prepare how you're going to deal and maintain the viability of organization so that you have another day to live. Um, so I don't know if I answered the question, but
You did. Thank you so much, Raimundo. I really appreciate that. And Maitzel, noted because the panel that we had yesterday talked about the cutting of programs and this and saving of money and how that connects to what we heard yesterday. And I would love for Ricardo to be able to chime in as well, especially since we're dealing right now currently, and how, are we thinking creatively, do you know what I mean? Like around community health, with these budget cuts.
Yeah, and I would also like to add a little bit about
Yes, please.
community clinics altogether as well. While I started in my own career, I actually started coordinating and planning all of the what we used to call the health pavilion for the Silicon Valley Pride at the very beginning back in 2013. So I used to coordinate all of the different health fairs or health pavilion that used to happen here in San Jose or Silicon Valley. And something that really was needed was actually the building trust and partnership with community agencies. That was a key component to be able to get them to be part of the celebration, to be able to have and bring resources to the LGBTQ plus community here in San Jose, and also being able to bring staff who perhaps are willing and able to work with the LGBTQ community without any stigma. And that was key for me working there and being able to talk about testing, test individuals, provide them with resources. Later on, as years went by, I then transitioned to a different positioning where I was now coordinating by National Health Week. And in this arena, very similarly, we had to partner up with a lot of community clinics to ensure that we were covering different areas of the county, not just solidifying or focusing on in the areas of San Jose, but also what are we doing with South County? What are we doing with North County? What are we doing with the different neighborhoods? Who is not at the table that we need to invite to be able to make this type of event successful? Now, unfortunately, going back now to the question that you asked me, Vicky, unfortunately, right now, the current climate that we're seeing is that the federal government at this point with HR1 is doing major cuts to a lot of the health systems and also the food assistance programs that we have. Now, many communities, especially Latinos and communities who are part of minorities, are going to be severely impacted, or they already are severely impacted. Why? Because earlier, as many of the panelists who are here were mentioning, just as Dolores and Raimundo and Luisa have talked about, the social determinants of health have actually, they're, they tend to determine our health outcomes even before we get to the clinic. So having said that, with everything that's going on at the federal level, at the state level, worldwide, with everything that's the stress of just turning on the TV, the frustrations, not having your family around, all that just escalates any health issues that we may have. And therefore, seeking help sometimes it becomes a little bit more scary for certain communities. Right now, we also have a lot of immigration enforcement that is happening in different communities. And that, of course, has been pushing people not to seek the services or help that they need. And therefore, right now, that is definitely going to impact, and it is impacting the health of our community, the services that are being offered, the way the services are being offered. Now, with the way that I see currently community clinics moving forward, we also are seeing a lot of different technology elements being incorporated into health services. We're seeing telehealth. We're seeing a lot of electronic record systems. Um, we're seeing a lot of appointments that can happen over the phone, video remote. And of course, even within that evolution of the services, we also have to keep in mind communities that perhaps may not be tech savvy. What are the other barriers that we're not thinking? How are we going to address those communities that perhaps at this point may be receiving services in person, may still need printouts? may still need home visitation. How do we do that in a way that we address their concerns, that we address their fears, and that we also prioritize their health and the health outcomes of that individual? Because at the individual level will also um, impact the community level health outcomes as well.
Thank you so much, Ricardo, for sharing that. I really, really appreciate it. I do kind of also want to bring it back to Dolores to talk about the way CHP, Community Health Partnership, started, right? In terms of like the federally qualified health centers and having this consortium. I know that Raimundo was also a part of that as well, but would love for you to share a little bit about that.
Thank you. I'm going to jump a little bit. I'm going to start out by stating that the answer to everything that Ricardo just talked about, all the horrible things like that, prompted the organizations to start an association of community health centers so that there would be power in groups. And the way that I understand it, correct me if I'm wrong, Raimundo, is that's when managed care came to Santa Clara County. And Medi-Cal and managed care has been a blessing. It has also been a curse, and I can explain that from my perspective anyway. And we wanted to, Raimundo and the team, at the time there were only 5 clinics, wanted to really engage with the county, to negotiate a fair rate. Because what had been happening up to then, and frankly, it continues to happen even here, is that sometimes we are seen as like a second class, system, and that we are here to have the county or the city or the state use us to provide the service at 1/3 of the cost. And that really needs to stop. If you really want to make a change in the world of public health, you really do have to start looking at that. That we provide the quality service that everybody else does, but we only get 1/3 of the reimbursement for the most part. So that was the reason for bringing this group together. At the same time, there were groups like ours forming throughout the state of California. There are now 16 associations of community health centers. We all work together. We all work with the California Primary Care Association so that it becomes a group, a movement. What's happening with what happened with the removal of Medi-Cal, it happened January 1st, and it's going to continue. The way that we're preparing is not individually. We're preparing by joining the county, by joining the Valley Health Foundation, by joining a group that the California Primary Care Association has put together to put our brains together and really look at the way that the money has been, what will be allowed, what kind of rates we'll be able to get. How do we ensure that the UIS population continues to be seen, and how are we going to pay for that? So there are ways. I am not a financial whiz, trust me on that. I think my skill is bringing people together and motivating them to do something, and I have been very fortunate in being in those, as you young'uns say, in the space of that. So really, if we don't approach this tragedy, these next 2 years, as a group, we will probably die. We will probably lose. Our message, our methodology has to come from a group that has power, but also working together with others that have power, such as our county government, our board of supervisors. So that is the role that Community Health Partnership plays and has played all along. When the ACA in 2013, when it was about to take effect, 2014, what we did is we marched into Supervisor Ken Yeager's office. I don't know if you remember that, Raimundo, but when we walked in, the supervisor sat up and said, "I've never seen this before. I've never seen 10 people, at the time, 10 clinics at the time, plus me, 11 people walk into my office, sit down, and start a conversation." So I learned a lot from that event. the outcome of that was $10 million to the consortium, which then we divided equitably, and nobody fought. I really thought some of them were going to come after me, like Lisa or Rachel, because they're the ones that hired me. So I now have and thus, if you want to just, I started out my comments an hour ago or so talking about how the vibe of unity is what really brought me into this field. And I have seen it over and over and over again. When we don't do things as a group, and we can argue all we want behind closed doors, just yell at each other or something. That's okay. That's all right. But then when you're going to speak in public, and then you speak on behalf of a group, not of yourself. You speak on behalf of a group that doesn't have a voice, and then the next step is you bring them with you and you sit down and say nothing and they let them talk. That's when you get really a tremendous amount of power there. And not only power, but trust, and you become legitimate at that point. So that's the approach that I have learned from working in this. This is my 16th year, by the way.
Dang.
I don't think Raimundo thought I would stick it out.
I was hoping.
Maybe she's leaving, get her out of here.
No.
So I think those are the challenges that the biggest challenge is we are expected to do everything and serve everyone, whether they have insurance or not, because that's part of the federally qualified health center regime laws. And I don't think that's fair. I really don't at this point. That's all I can say. I don't think that's fair that we have allowed that to happen. And I'm worried. I'm very worried.
Thank you so much, Dolores, for sharing. I really appreciate you talking about advocacy and coalition building and,
Yeah.
going to, to advocate, at the Capitol. We have our very own Dr. Angie Buckner is taking 10 students, undergrads, and I believe possibly a Master of Public Health student to the Capitol next Monday to do some advocating around health. And there's several students that are in this room right now that are going to go. So I really appreciate you bringing that point of view. I'd like to just bring it back to Luisa. If you wanted to share, any, of kind of like the challenges and lessons learned from your experience with community health.
Well, the world of the 70s that I started in, we're in a different world today. And so while we were able to, as Ramuna was also talking, we had clinics in schools, we had clinics in churches, we had clinics in old abandoned gas stations, wherever we could. And most of the clinics were run by unpaid volunteers or paid, as I said earlier, $15 a week. We can't do that kind of exactly the same today. But the reality of the fact, just to talk a little bit more concretely about the challenges, is that most of the health centers have populations of anywhere from 30 to 50% that will no longer be covered at the high rate of Medi-Cal that most of the clinics get. Will be paid, instead of saying $400 or $500 a visit, we might be paid, $50 to $100 a visit. It's a huge challenge to our revenue at a time when we're already probably clinics, that your fulfillment doesn't come from getting a big paycheck. Your fulfillment comes from the work that you're doing and seeing that you're changing people's lives and you're making a difference in your community. And so we're already being paid 15 to 20% less, than Kaiser and Stanford and other places. And then to also lose 20% of our revenue due to the cuts in Medicaid that are coming up. And people, we'll still see people, they'll be shifting to sliding fee scale. Our cost per visit at Ravenswood is about $800 a visit when it counts everything. Our data warehouse, our compliance, our quality, our HR, you add all the responsibilities, regulatory responsibilities on top of just direct care, it's significant. And what we get at our highest Medi-Cal reimbursement rate, PPS, it's like 560. Our clinic, but all clinics are different, and will be, at least half of the population will be going to, perhaps 100, maybe $150 a visit. So how do you make up that loss? And then on top of it, we still are facing the potential threat of, as a federally qualified health center, of being targeted for giving, quote, federal funds, even though it's only like 7% of our entire budget, federal funds to people who are, quote, unqualified aliens in the country. And if that happens, could we lose our federally qualified health center status? So the future of community health centers and federally qualified health centers is indeed at its most critical point ever in its history, with an administration that still has 3.5 years. Is it 3.5 years? 2.5 years. 2.5 years. Am I counting right? They've been in 1.5, they get 4. What? 4 minus 1.5 is 2.5, right?
Whatever it is, it's too long. How's that?
2.5 years. I mean, I'm laughing, but it's, people think, well, maybe in the midterms, we get enough Congress people in there that will try to at least stop the bleed. But there's and more threats of cuts coming down the road to pay for the war in Iran. And so we're facing a challenge we've never had before, because we were on the crazy thing is we had gotten to a place in community health where we provide and could prove that we provide some of the best and high quality healthcare in the country for people with the greatest disparities in needs. We have proof of it. We have research. We have everything to show that addressing, the whole person care, not only their resources, but behavior health, and making sure they have pharmacy, and making sure, new moms have home visits, all these kinds of things that community health centers do that have helped our population improve their general health, is being sort of slammed to the point where can it even survive? And we are on a different kind of point, because in order, the clinic that I helped start in East Palo Alto, I was there for 21 years. When I came in, we had a $2 million budget and 23 staff. When I left, we had a $62 million budget and 364 staff. And we were bringing in probably 75% of our revenue from patient visits at the time, and then also we were getting a federal grant, and then some other donations and grants to make up the full budget. And how do you go from there and lose 20% and keep everything operating and going? I mean, it's not only a financial nightmare, but we are committed to caring for our patients. So how do we do it? So I'm also involved in Rotacare Bay Area. I'm on their board, and Rotacare has these free clinics that are open 4 hours a night, once a week. And they see, 15 to 20 people a night. That's not going to take the place of 500,000 people in the Bay Area that are potentially going to lose their Medi-Cal status. But I'm just talking about Medi-Cal. There's also all the people who lost subsidies from Covered California that dropped out of, they dropped their health insurance because they couldn't afford it. And they're showing up in the emergency rooms for their diabetic and hypertension medicines. So hospitals in the Bay Area have increased emergency use by 30% with people with primary care issues, because where do they go? And as federally qualified health centers, we have to charge them our full price. We can't give them a discount. And so if they go to the emergency room, maybe they get charity care. I don't know how they're going to manage it, because they, if they don't meet certain financial criteria, they may get a bill, a terrible bill that then they end up in collections. So if you think about the the effect of all this, the stress, the emotional impact, all these kinds of things, it as a society, it's a greater issue than just our clinics. It's a societal issue that's really going to hit us hard. It started in January and it's going to get worse after July 1st this year. And so, you know, we don't even have we don't have an answer, but we believe in what we're doing and we're going to try to figure something out. The free clinic groups and the FQHCs are talking to each other, also with Stanford, Communal Hospital, the counties, and trying to figure out what can we do to continue to provide access that will not result in just cutting services because we can't afford to pay for people. So do we get a cadre of retired baby boomers, you know, to expand volunteer clinics? I don't know. I don't have an answer. I just know that, you know, all of us have struggled
Mm.
all our lives to make access possible for people. And to think we're going back to a time where we're just refusing service. We're going to tell people they can't be cared for, that children can't get developmental exams or vaccines because they've only had a green card for less than 5 years, and so they no longer will be covered by a federal program that covers vaccines for children. Are you out of your mind? So we've got to figure out how to do this. And like I said, I think we have to, as Dolores says, we have to get together, keep our heads together, and we've got to make it happen because we're not going to let people down.
Thank you so much,
May
Lisa.
I ask a question, Vicki?
Yes.
Well,
Yes.
yeah. So your group is going to Sacramento tomorrow.
Next week.
Yeah, I hope that you have an opportunity to advocate for the bill that that will not remove the PPS reimbursement. I believe it's AB 278, I believe. I don't remember, I think I'm correct. But that is really, really important. If you can, it's a simple.
Excellent.
Mhm.
Dr. Angie Buckner is in the audience right now. So, Dr. Buckner, and I'm sure that was already on the radar.
Okay, good, good,
But
good.
thank you so much. I want to be cognizant of time because believe it or not, it's already 2:33, and I feel like we could keep on having this conversation for much longer. But I think I want to wrap it up with, obviously a message, of hope to our students, right? Like, we have, many public health students who, are here in community health because they want to make a difference, or in public health because they want to make a difference. And what do you feel like, what are some of the skills that it's going to take, to make this happen, to protect community health? I think you all have talked already so much around, advocacy, and building together, as a unit. But any last words of hope? And I'm gonna start with Ricardo, if that's okay.
Of course. Of course. And thank you. Thank you for having me here. Thank you for the invitation. And I will say that my message is this. Uh, Community health has never been an easy work, but it has always been meaningful. And today, more than ever, it is an opportunity for us to reimagine systems and the way that perhaps the future of community health work and community clinics is going to be moving forward. Hopefully, it will improve after the next couple of years, and we can only continue to go up. Right now, we're not in a good place, but we do have a lot of great minds, a lot of great partnerships. And as Dolores and Luis and Raimundo and everyone here have mentioned, coalition building is key element in continuing to pushing this work forward. So building trust with our partners, with our communities, and ensuring that we are pushing for access, not only thinking in English, but also thinking about other languages and other abilities that might be needed for our community to access the services. And thank you.
Thank you so much, Ricardo. Dolores or Raimundo or Luisa, any words of hope, or what the skills that are needed to keep community health alive?
I would say, first of all, I want to tell everyone that I am always really happy to take students, particularly master's level students. And we've had some incredible students from San Jose State, so you are always welcome if it meets your needs. And the other piece is, and when I think of the future, I think of people at age 13 to 30. These are the folks that are going to take over for us for the ones that, like Raimundo, Luisa, and I. So I say, keep your eye on the mission and the social rights or social justice. That's what's going to keep you moving. The money will be great or not, but that will not make you happy. I can guarantee you. It's that sense of a purpose in life and a purpose of doing good for others, and the camaraderie that you get as you come together with other folks that think like you. That's going to give you life and energy. That's what makes me get up every single morning. And Raimundo knows I often have called him at 5 in the morning, so he knows not to come up. I call, yeah, Vicky, Dr. Vicky. I know. I'm gonna try to stop, but it's kind of impossible at this point. So I want to tell you that I have so much hope because when I meet some of you, some have come to my office, they come to our events, and I hear you speak, and I hear all the 100 participants. I'm very impressed, and really, really hopeful. So I unfortunately, we got to do something now. But I know that you guys are going to take over, and whatever we have lost in these last 2 years, you will bring it back. It will look different, of course. It has to look different because you're creating it, not me anymore. So that's a piece that I'm really happy about. I have a 12-year-old granddaughter, and when I hear her talk about social justice, it just makes me cry. She's only 12.
Mm.
She has grown up with that perspective, so I think most of us are already working on it. And I thank you, Dr. Gomez, I thank you for this, but I thank the 100 students that are in the screen here, because I think it's really wonderful that you're together. You're going to Sacramento together. You're going to break bread together. You're going to make mistakes together. And what we don't want is the nonprofits to go after each other because they're going to throw crumbs at us. Just know that. Nos van a echar un pedazo de pan, and then we're all going to start fighting over that pan. No, we're not. Not this time. We're not. We're going to say things like, okay, maybe I'll cut the bread in half and you take a quarter and I take a quarter. And we come together instead of I want the whole thing. That's my lessons learned.
Thank you so much, Dolores. I want to be cognizant because we only have a few minutes, and I know that we want to open it up to at least a question from the audience.
Yeah.
And Meitel is always advocating for the youth voice, to come through. So I really love that you talked about, do you know what I mean? Like, bringing in that younger generation, which many of our students that are here, are from that generation. Do we have any questions at all for our panelists? A lot of folks were messaging me during this that they want the recording already. I was like, we haven't even finished it yet. They're already asking for the recording. I hope that this, has been, something that can bring us hope. Maisel, did you have any questions that you would like to ask? I know you always have good questions.
I mean, first, I would just like to thank all of you because sitting in these spaces re-energizes us as lecturers, as professors, as faculty for students. So this re-energizes myself. But what do you think is going to be the driving force for students as you have seen students activate in the past and throughout history? What do you think has been the one thing that has like brought people together and what will help our students understand how they could bring each other together during this time? And we're in a different time. We have a lot of students that really went through school online through COVID. They're still dealing with a lot of those different aspects of learning. And I'm wondering what your suggestion is for students to really rally to, and I've been saying it lately, get scrappy. Like how do we bring students together? What has worked in the past?
So when I went to UC Santa Cruz, a bunch of us got together to talk about what community meant to us and who we identified with, especially the folks like myself who are biracial. And we talked about doing meaningful work and finding a place, and most of us went out and volunteered for either new nonprofits or community organizations. And I will say that the best experiences of my life have been as a volunteer. Actually, in my youth, I didn't have, we shared houses. A whole bunch of us lived together on mattresses on the floor, but it was the camaraderie and um, all of us working really hard for something that was very meaningful. And I will say that we learned skills. We learned all kinds of skills that you may not even get in a real job because there's so much hierarchy and uh, parameters. I'm thinking that it's really useful coming out of a master's in public health, particularly if you haven't actually already worked in community health directly, to find opportunities. Could be a paid internship. I realize that people need money, but to actually volunteer and be able to experience what it's like and learn from that experience will help you, because I think, as Ricardo said, we have to reimagine things, and it's hard to reimagine things if you haven't actually had the operational experience of being in that environment. The other thing is, every day wake up, it's a new day. Every moment is this is the one moment you have to make a difference in the world and in your own life. And having a purposeful, principled, and productive life means that, to be fulfilled. And we're perfectly imperfect as human beings. So that means that, we're not designed to be perfect. And so we are going to make mistakes. We're going to go down a path that maybe isn't the path that is our passion, but we can switch paths, just as Raimundo was saying. And we switch paths and we find our place in the world, and that makes up a life.
Thank you so much, Luisa. Raimundo, anything to add here around what is it going to take to inspire students to get scrappy, as Mike said? Because I feel like you were scrappy when you were at Stanford, and you're muted.
We were all scrappy.
Yes.
No, we were all scrappy. Yeah, yeah. But I think it was just at the time listening to the issues at hand, right? And then trying to get involved and participate. And sometimes it was challenging, maintaining the balance between school and the issues. And some people went overboard on addressing the issues and needed some balance. But nevertheless, I think it was just being involved and trying to address those issues that are important to you, that make a difference in people's lives, I think. And for us, those issues were, creating a greater balance in terms of access to admissions and the staffing and of course the civil rights of us and for us. Um, what I want to talk a little bit about, just an ending. I think one of the things and this is at the organizational level, okay, because I think morale is a big issue at the sites. And I think to the extent that the leadership can promote hope, I think hopefully they'll be more successful, because I think people are concerned and aware and afraid at times because they hear all this stuff, but sometimes we don't communicate as leaders the strategy and what we're going to do. And I think it's really important to do those things on the site that help people understand where you're going through, what their role is versus, the leadership role in terms of trying to make it better and understanding, like with the pandemic, that there may be, challenges to this, but at least keeping people motivated in the same direction. The other piece that I wish I would have done more of, was at least within the organization, the history of the organization and how it developed and why it developed. I think, to me, every time I would talk about a story, people would be engaged about the development of the organization because they didn't know, right? And to the extent that leadership can promote the history of the organization and why we're here and why we're doing it, it creates that desire to keep it going. And I think that's some of the things that I would also, hope with. And then the other things, I think, again, I think this has already been said. I think advocacy, partnerships, and awareness, are all things that we need to come together on. And for Gardner, for example, we've had different partnerships. We've had partnerships with the county, with Lucille Packard, the School of Arts and Culture, all who helped us create health centers in the local community. So all those partners hopefully can come together and help. Just like in the pandemic, right? We had a bunch of partners. We had the county, we had the state, we had the nonprofits, we had the community health partnership, we had the schools all participating in one effort to try to make it better. So those are the types of things I think they're going to need to continue to be.
Thank you so much, Raimundo. We are at time. It is 2:46. I know that students have to get to their next class. So I just want to say thank you, a heartfelt thank you
Thank you.
to each of our panelists today and your perspective and what you have shared. And again, like just how important it is for us to honor the past and how that past can shape the future. So thank you so much. In the chat, we have a form to enter into the raffle. We have some prizes to give out, and just thank you, students. Thank you. I see some MPH students in here. I see our undergraduate students from our 104 class, and I just want to thank you all very much for taking the time. And thank you so much to our panelists today.
You're welcome. Thank you for inviting.
Thank you for inviting. Yeah.
Salud.
Thank you for the opportunity.
Bye.
All right. Have a great rest of your day. Thank you so much.
Good luck,
Thank
everyone.
Thank you, Dr. Vicky. It was a pleasure.
Dr. Vicky.
Thank you, everybody.
Dr. Vicky, that's what I call her. Yeah.
That's right.
Thank you.
Doctora.
Bye.
Thank you so much.
Bye.
Thank you.
Take care. Okay.
Bye.
Okay, goodbye.